Hi. um, for our behavior replication project, my group chose to do the article by Pence, St. Peter, and Teacherelt that focused on increasing accurate preference assessments with the use of pyramidal training. The purpose of our replication study was to better understand the effects that pyramidal training has on accurately implementing preference assessments by the providers who work with these children in clinical or school settings. And in our project, we worked on training each other using a two-tiered pyramidal approach to properly deliver multiple stimulus without replacement, paired choice, and free operant preference assessments. The initial training for the first tier participant was from a board certified behavior analyst who did the baseline and the initial training and provided feedback and how to use feedback. And then that was used throughout the course of pyramidal training. The participants in our study, in our replication study, are all applied behavior analysis program graduates at Ball State University. Starting with.
My name is Alicia, and I'm a special education teacher for individuals with emotional and behavioral disorders, and I'm currently receiving my supervised independent fieldwork.
I'm Ann Galliano. I'm an ABA line therapist at an autism clinic receiving supervised independent field work as well. I currently work with children the ages of 3 to 13 with autism.
Hi, my name is Lauren Saunier. I am a registered behavior technician as well, receiving supervised independent fieldwork experience, and I work with children from the ages of 2 to 10 years old with ASD.
I'm a paraprofessional at a preschool serving both neurotypical and children with developmental delays, and I'm currently not receiving supervised independent fieldwork.
Hi, I'm Sophia Risby. I am an RBT for children at a clinic, and I do in-home services. All the children I work for have an ASD diagnosis. I've served children ages 2 to 16. I'm receiving independent supervised field work and have been since June of last year.
Hi, I'm Whitney. I'm also a registered behavior technician, receiving my independent field work supervising. I work at a clinic where all of the children also have an ASD diagnosis, and all of my clients are from the ages of 2 to 12 years old.
Pyramidal training increases our accuracy in delivering preference assessments to each other and then generalizing the skill once it has been mastered into the natural environment with the clients, which needs to be 90% or higher with a foundation of a two-tiered pyramidal training approach. So broken down, this approach involves training a small number of individuals who will in turn train additional individuals. Pyramidal training is a train-the-trainer model that has been used to efficiently teach professionals or parents how to use behavioral procedures. In pyramidal training, a small number of individuals are trained by a higher educated professional, and then those newly trained individuals train a second group of individuals that are larger than the first, and then the process continues from there. In this behavior change research study replication that we've chosen, we've used pyramidal training with an initial professional training from a BCBAD, who in turn teach several graduate students how to implement preference assessments in a clinic or a school setting. So each training and tier instruction, modeling, and feedback read.
The MSWO assessment is a multiple stimulus without replacement preference assessment. That involves the person selecting an item out of an array of 5 to 7 items, being allowed time to consume that item, and then that item is removed and the remaining items are rotated and the individual is asked to select another item, and that continues until the final item is consumed. The dependent measure of this particular preference assessment is the percentage of times that an item is selected out of the number of trials that it is presented. There are a couple of advantages to the MSWO preference assessment. The assessment is less time consuming than paired choice, which you'll hear about in a second, and it results in a hierarchical outcome, which would show most to least item preference. And one of the limitations is that the person needs to be able to scan and select from a larger number of items, which we already know can be difficult for some individuals with disabilities and especially autism. Paired choice. The paired choice preference assessment involves the person selecting one of 2 items presented during each trial. The item is paired with every other item in the assessment in a left to right presentation. The dependent measure of this preference assessment is the percentage of times the item is selected when it's presented. It also has a few advantages. The preference assessment type may help identify potential side biases. It also, like the MSWO, results in a hierarchical outcome of item preference from most to least. And it requires the individual to only be able to scan and select from an array of 2. So that may be one reason the paired choice would be chosen over the other preference assessments. One of the limitations is that paired choice takes more time to complete than the MSWO. And free operant preference assessment involves unrestricted access to multiple items at once. The dependent measure of this assessment is the amount of time allocated to the manipulation of each item by the person. The advantage for this assessment is it does not restrict items that are included, and one of the limitations is that it's less likely to result in a hierarchical outcome than the other preference assessments that were utilized in the study.
So in this, in our research replication, the actual article was broken into 2 experiments, and so we did the same thing. Whitney, which is myself, who will be referred to as T1 for the remainder of the presentation, was initially trained on multiple stimulus without replacement, pair choice, and free operant preference assessments by her PhD, LBA, BCBA-D on-site supervisor. She obtained 90% accuracy in each preference assessment after training. Tier 1 participants were Sophia and Lauren, who will now be referred to as 2A and 2B for the remainder of the presentation. In experiment 1, trainer 1 was provided with data sheets, a step-by-step protocol for each preference assessment, as well as additional information on how to properly give constructive feedback for steps that were performed incorrectly, and positive feedback for the steps that were performed correctly. This was given before tier training began. 2A and 2B trainees received didactic information about each preference assessment prior to baseline, but there was not much explanation. After that, 2A and 2B trainees were handed data sheets, as well as 7 different reinforcers to choose to use during the baseline and training for themselves. The trainees selected a number, either 1, 2, or 3, from an envelope that will determine the exact number of baseline days that they had to collect baseline for, as well as the number of treatment days, or until 90% mastery was achieved. From a second envelope, they selected again which preference assessment would be done first for baseline. After baseline was conducted, P1 instructed and modeled each preference assessment, and preference assessment protocols were given to both trainees 2A and 2B. Alicia, who is a participant in the second tier, who will be referred to as 3A later on as well, she collected IOA on trainee performance of preference assessments, and she also collected data on treatment fidelity, on the trainer's use of feedback. After initial instructions were complete, trainer 1 provided feedback and modeled correct responses for 2A and 2B. And then the trainees were required to achieve 90% mastery of all preference assessments before ever being able to move on to the next section.
So they're trying to lower and control the price to drive other people out of the market. It does drive other people out.
And experiment 2 is the second portion of our 2-tiered pyramidal approach, where 2A and 2B trainees now serve as the trainers for tier 2 participants, which is Alicia, who will be referred to as 3A, Leslie, who will be 3B, and Anne, who is 3C.
More expensive.
2A and 2B trainers were presented with data sheets, preference assessment protocols, and also additional information on how to correctly provide constructive or positive feedback. 3A, 3B, and 3C participants had little to some knowledge on preference assessments, only because of ABA coursework, with the exception of 3A, who is Alicia. Because of the limited number of group members, she also had to serve as our IOA observer in Tier 1, so she might have had a little bit more knowledge on preference assessments. No supplemental information was ever given besides minimal verbal information about the preference assessments to trainees 3A, 3B, and 3C. Trainees also each selected a number, either 1, 2, or 3, from an envelope to decide the number of baseline days and intervention days to collect, as seen in experiment 1, as well as selecting the preference assessment choice for baseline as well, the first preference assessment they would do for baseline and training. Then trainer 1 served as the IOA observer for the tier 2 trainers, 2A and 2B, when they trained 3A, 3B, and 3C, as well as for treatment fidelity in this tier. And then training was implemented the same as in experiment 1, also using instruction, modeling, and then feedback, where trainers provided these 3 things to the trainees. And 90% mastery was also required to move on to the next section.
Hi, I apologize for the delay. So we used materials, data sheets we needed for baseline, intervention, generalization, and IOA. The sheet you see on the side was used for baseline, intervention, and generalization. Data sheets for training to collect preference assessments, writing utensils, the envelope with preference assessments listed, preference assessment protocol, feedback protocol for trainers, and 5 to 7 tangible items, at least 1 edible. Google Hangouts live video chat was used, and supplemental article, which you can find in our references we used, and treatment fidelity and data sheets and a rating scale. And I will go over that in the next slides with you guys. The materials for the reinforcers, we all chatted and we discussed one of the type of reinforcers we liked and that would be really useful to use over the format that we had to use it for, which was Google Hangouts. So we used the candy chocolate M&Ms, Uno or another. We didn't want anyone to go out and buy anything, so just another card game they had. And this could have been available via just playing the card game online. Listening to a song via iPad, watching a preferred YouTube video via iPad, social media such as Snapchat, Facebook, or Twitter, you're via phone, potato chips because we all agreed we like salty food, and then adult coloring books / coloring sheets that we just printed out online. And then Whitney will go over the rest of the materials for treatment fidelity and IOA sheets.
As mentioned previously, because of the limited number of group members we had, our IOA observer also collected treatment fidelity. So we just figured it would be easier to just have one sheet where all data could be collected at one time. So in the first column, you'll see MSWO, and then there's a section for pair choice and free operant, and we put a section for trainee and trainer. So one is IOA, obviously, and the other one is treatment fidelity. And this sheet was just used to jot down to collect data on if the trainee performed each preference assessment correctly, and if they delivered the feedback that was needed to the student. And then in the trainer section, treatment fidelity was collected on if the trainer provided the correct feedback for the trainee. So if there was an error, then constructive feedback would have needed to been given. And if it was performed correctly, then positive feedback would have needed to be given. And if no feedback was given, that was recorded, and it was all done by the same observer, and treatment fidelity percentages will be talked about later on as well in the presentation.
So back to what Whitney was discussing, the trainer feedback protocol involves positive feedback, constructive feedback, and omitted feedback. For positive feedback, this is where the trainer would praise the trainee for steps completed correctly. So for an example, this would look something like, great job removing the item that was selected by the client in MSWO, or I like how you remembered to switch the position of the items in paired choice preference assessment. So this is what positive feedback would look like. The second one is constructive feedback, which is statements outlining an error that the trainee made, as well as review the steps that were completed correctly. So this would look like, try to give the client a few more seconds to consume or manipulate the item before taking it away, and as well as great job not forgetting to remove the selected items each time. Inaccurate feedback will be scored if there is an error in the trainee's area and constructive feedback is not given, or if there was no errors and constructive feedback was given instead of positive feedback. For the third one, omitted feedback, this is instances where the trainer does not give any feedback where feedback should have been given. So inaccurate feedback will be scored if no feedback is given where it is due.
So the next three slides are the data sheets that were given to the trainees before their intervention sessions, as well as the generalization sessions. And these forms were not actually used during the intervention phases, but they were used during the generalization phases in order to collect the student responding data. And these data sheets, we created them so that they could align with the study, so that we could replicate it as close as possible. And in the study, they were given these data sheets. However, the data sheets were not provided for us to replicate in the study, so we created our own data sheets just so that we could replicate the study as close as possible. And so this is the second data sheet, which shows the paired stimulus. So for the trainees that were conducting the paired choice preference assessments, they would use this data sheet. And then for the trainees conducting the next preference assessment, the multiple stimulus without replacement, they would use this data sheet to record the student responding data.
So our baseline procedures were the same for experiment 1 and 2. So we started with the trainee selecting a preference assessment from an envelope without replacing it back. The trainer would then say, you selected MSWO paired choice. Every operant, show me what you remember about the assessment. Trainees would either attempt or not attempt to conduct an assessment. Trainers would collect data on the sheet of correct, incorrect, or no response. No attempt resulted in a 0% of steps completed correctly. If part of the assessment was completed, then the remainder of the steps would be marked as incorrect. These steps would be repeated for each preference assessment. A new session would begin from the next time the trainee selects a preference assessment from the envelope. The supervisory BCBA served as Tier 1's baseline assessor, Tier 1 served as Tier 2's assessor, and Tier 2 served as Tier 3's assessor. We were assessed on all 3 assessments. Everyone's scores varied during baseline. Though some of us scored higher during baseline, none of us met 90% accuracy criterion. For experiment 1, the baseline range of all group members for MSWO was between 18 and 27%, 20 and 30% on paired choice, and 0% for free operant. The baseline average for all group members for MSWO was 15%, 23.3% for paired choice, and 0% for free operant. During experiment 2, the baseline range for all group members for MSWO was 64 to 81%, 60 to 80% for paired choice, and 50 to 71% for free operant. The baseline average for all group members for MSWO was 72.6%, 66.6% for paired choice, and 57% for free operant.
We understand that the pyramid training sequence can be difficult to understand here in sciatic. We made a visual representation of what it looked like so you guys can better understand. So you can see at the top that she was on the first tier, and she was trained by her BCBA D, and then she conducted a session with us via Google Hangouts, Lauren and Sophia, and then Lauren trained Anne, Leslie, and Alicia on paired choice, and then I, Sophia, trained Alicia, Leslie, and Anne on MSW and free operant.
For the intervention phase, that was our actual training portion of the experiment. For experiment 1, each paired choice session consisted of 10 trials, each MSWO session 7 trials, and the free operant sessions were 10 30-second intervals, which a total of 5 minutes. The steps that we took were first the trainer would review with the trainee. The trainer stated the name of the particular assessment and then reviewed how to conduct the preference assessment, including how to collect data on student responding, such as if a student attempted to select more than one item during the paired choice trials, a therapist should block and represent the trial, or say in MSWO, if there was no choice made, or in paired choice as well, a trainer was to prompt the student to make a choice. The trainer modeled preference assessment, explaining how to respond to the student, giving a visual example of each step. And the trainer answered any questions of the trainee. The trainer said, well, here are some materials, and presented the data collection sheet, which we all had. Toys and or edibles were set up as you would to present. The trainer would say, I'm going to be the student, please run and then state the name of the preference assessment. Then the trainer played with the items, give the toys back to the trainee when prompted by the trainee. The trainer refrained from problem behavior while acting as a student. And the trainer included for this period of time, 2 to 3 trials selecting 2 items simultaneously. And this was to help model how to react to when say the trainee when the trainee tried to select more than 2 items, the trainer would block and then represent the item as stated in an earlier step. In paired choice and MSWO assessments, the trainer didn't select an item within 15 seconds to see how the response for that. In free operant assessment, the trainer stopped playing with the items at least 15 seconds. The trainer collected data on sheets, and after each training session, the trainers referred to the data sheet for that particular session, and the trainers provided feedback, which included explanation of the error, model of correct responses to the errors observed, as we talked about earlier as well. The trainer continued training on a particular assessment until the trainee completed at least 90% of the steps correctly during at least one session. That was the mastery criterion. Once mastery was achieved by a trainee, they moved to another trainer for training on a different assessment type if we would have done that. Training ended after all 3 assessments were completed to mastery, 90% or greater integrity. The range of all group members was MSWO, 64 to 100. The paired choice was 70 to 100%. The free operant was 63 to 100%. And the average of all group members was MSWO, 92.6%. A paired choice was 90.8%. And free operant was 90.9%. And in experiment 2, the same guidelines and steps were used as we just went over in experiment 1, but the difference were the trainers and the trainees, as we talked about earlier, because we're doing the pyramidal training. The tier 2 trainees were not as knowledgeable in preference assessments as tier 1 trainees, so that helps account for the lower baseline. And the range of all group members for MSWO was 91 to 100%. Paired choice was 95 to 100%. Free operant, 93 to 100%. And the average of all the group members for MSWO, 98.4%. Paired choice, 99.6%. And free operant was 99.4%.
So in the original study, only generalization was done in experiment 1, but since we had such a small group, we added generalization to both tiers. Generalization sessions occurred 1 week after the training sessions. Trainees were required to demonstrate all 3 preference assessments, and trainees selected which preference assessment was conducted first. And this continued until trainees completed all 3 preference assessments. If performance decreased below 80%, feedback was given through modeling and explanation of errors. None of our group members dropped past 80%, so this would have just been the steps we would have done.
This slide we're going to talk about our Inter-Observer Agreement, or IOA. In Penn's 2012, IOA was taken during 52% of the training procedures. IOA was taken during all sessions for the purpose of this project, since ours was a smaller pool of people. In Experiment 1, 3A's IOA observer for T1 training session was 2A and 2B training, Tier 1. In Experiment 2, 2A was the reliable observer collecting IOA for 2B's training sessions with 3A, 3B, and 3C trainees, the second tier. 2B was the relay observer collecting IOA for 2A's training sessions with 3A, 3B, and 3C, Tier 2. The average IOA across all sessions was 98%. This is in line with the study, which was at a very high percent of IOA of 97%. The treatment fidelity was taken during all sessions. In Experiment 1, in addition to IOA, 3A took treatment fidelity on trainers' feedback for T1's training sessions with 2A and 2B. These treatment fidelity data sheets were seen earlier in our presentation. Experiment 2, 2A was the relay observer for IOA and took treatment fidelity for 2B's training sessions with 3A, 3B, and 3C trainees. 2B was the relay observer for IOA and took treatment fidelity for 2A's training sessions with 3A, 3B, and 3C trainees. The average treatment fidelity across all sessions was 97.3%. The range was 87.5 to 100.
In the results section and discussion of this project for baseline, my baseline was collected by my BCBA, and I did 2 baseline days throughout for baseline. I also did 2 trainings and 2 generalizations just to ensure that I had it down packed. And for MSWO, my baseline was an average 77%, and my range was 8%. For pair choice, my baseline average was 65% with a range of 10%. For free op, my average was 57 with no range. And then intervention, I jumped to 100% in all except free op. The first session was 90 and the second 100 with an average of 95% and a range of 10. And then I was able to keep above 90% at actually 100% for generalization. Sophia's results for her data was MSWO, she had 64% in baseline, 60% in pair choice, 50% in range. Lauren had I'm sorry, we're having some complications.
Can you hear me?
Yes, now I can. Lauren, can you talk now?
Can you hear me?
Yeah, we're on Lauren's. I just did mine, but I'm not sure if it recorded.
No, I didn't. I tried to help you.
Okay. So what do I need to talk about?
I said your baseline, but I didn't get to finish your intervention or your generalization.
Okay, we apologize for the technical difficulties. I'm going to start over and just discuss my results with you. So one of the many limitations of doing things over Google Hangouts, but my results were relatively average, which I was unhappy with considering I should know these things as an RBT, but I immediately increased during the training sessions to 100% at everything except for free operant, and then generalization I increased to 100%. I was really happy with those results because now I feel a lot more confident to do these preference assessments with my clients. The average in baseline was only 58%, and the intervention was 96.7 for intervention, and then an increase of 100. So that's really awesome. Lauren can move on and talk about hers.
For mine, pair choice baseline, my results ranged from 70 to 80% with intervention following, which was 90 to 100%, and my generalization resulted in 100%. SWO baseline, my results ranged from 72 to 81% with both my intervention and generalization following with 100% as well. And lastly, my free operant baseline, it ranged from about 57 to 71% with intervention and generalization as well being 100%.
So for my data in baseline, I had a little bit of knowledge with conducting the MSWO and the paired choice assessment, but I didn't have really any experience conducting the free operant, so that's why that was so low. But during the training, I chose, or I drew a 1 out of the hat, but as you can see for the free operant, I didn't meet the criteria for the first time, so that's why I had to redo it again. But then as you can see, after training was conducted, I was able to have 100% mastery for generalization for all 3 preference assessments. And you can see that from the average from baseline to intervention, it increased significantly. And for most of them, it was 100%, except for the free operant, which was 94% accuracy.
And now Leslie's going to talk about her graphs.
So for my baseline, I had very little experience, so that's why it's so low. During intervention, it increased significantly. I didn't reach 100%, but I did reach about 95, 96%. And then it stayed about that during the generalization phase.
All right, now Anne will talk about her graphs.
I had no formal preference assessment experience, so my baseline, of course, as you can see, I really didn't know anything about any of them. So I had a significant increase in the training period and was able to sustain that over the generalization phase.
All right, guys, let's wrap this up with what we learned. This was really significant to all of us. Our baseline data revealed moderate to low knowledge of administering preference assessments before premental training was utilized, which is really unfortunate considering we are all graduate students at ABA and practicing in the field daily, so we really needed to increase that preference assessment knowledge. Intervention baseline revealed a significant growth in the preference assessments administered, and the best thing was the pyramidal training proved to be an effective means for efficiently teaching a small group of professionals who in turn train the second group. So we were able to train each other rather than having it work in a smaller, like one-on-one session. Although the data showed a positive increase of preference assessment administration, further research is needed to determine how effective pyramidal training can be for other behavior analytical procedures, for instance, a larger group than our small 6 people, which leads to limitations.
And then, so we tried as best as possible to replicate the study, but there were still some limitations that prevented us from replicating it exactly as the study intended it to be replicated. So our first limitation was that we had to have an untrained IOA for our first tier. And in the article, they had trained observers who were not participants later in the experiment. So because of this affected 3A's knowledge of preference assessments in Tier 2 because she was the IOA observer for Tier 1 before her intervention took place. And then also the IOA observers were also the treatment fidelity observers because of the small group of people that we had. And then another limitation was that our trainers sometimes had to teach all 3 assessments to the trainers or to the trainees, again, because we didn't have a lot of group members, whereas in the article, there was 1 trainer for each type of preference assessment. And then finally, a limitation was that we had to deliver all of our training feedback via internet and conferencing, and we couldn't do it in person because we all live in different states and cities. So we had to be really explicit and really communicate a lot on the steps that we were taking in order to give the accurate feedback.
Now you can view this just for our content contribution. We all really worked hard together to make this worked and cohesive, and we had a lot of teamwork and a teamwork effort on this part. And then lastly, if you would like to see our references, the Pence article, which is listed as number 4, is what we replicated, but we used a lot of supplemental materials, which you can view here. Thank you guys so much for listening. We really appreciate it. And Dr. Mujal, you can feel free to email us with any questions you have regards to the study. Thanks.
Thank you.